because you know that a diabetic patient and his family, they have to adjust a lot to this disease, like modification of diet, physical activity, and lifelong medicines. And not only that, they need more care, more attention. They require frequent visit to doctor, frequent blood test, and it's a financial burden. So it's completely a stressful situation to the entire family. So in such cases, from a phlebotomist who collects a diabetic patient's blood to a lab technician who performs a diagnostic test to a biochemist or a pathologist who interrupts and signs out a report, and a physician who starts a treatment based on the results, any error in this chain is going to significantly affect the patient management. So as a healthcare worker, it's our duty to provide our patients with information that is necessary, appropriate, and affordable to them for effective management and to have a better life. So coming to the lab test in diabetic, we know there are many basic tests and many complicated tests.
You're presenting something.
Hello?
Yeah, we can't see your screen.
No, I'm not presenting, sir. I'm talking only.
All right.
Okay. Okay. So as we know, there are many basic tests like blood sugar level, HbA1c. You know, even from a small lab to a fully automatic lab, every lab offers this test. So it's about the quality of the test we report is more important nowadays. And not only that, even patients themselves are very familiar with rapid testing like glucometer testing at home. And they know each and everything about diabetes through Google and other search engine. Hence, a strong knowledge of the principles of the test, their indications, their interpretations, and their fallacies is something we all have to absolutely possess as a healthcare worker to provide the patients with their accurately determined results and to answer to their queries. So we should know A to Z about diabetic and its related subjects. So therefore, as an initiative taken by Diagnopool organizers, here we have a talk on the role of laboratory in diagnosis, monitoring, and management of diabetes. To speak about the same, we have here with us Dr. Divyalakshmi. She is an MP pathologist. You all will be very familiar with her since you are attending many Diagnopool webinars by now. She is one of the co-founder of Diagnopool. She studied her MBBS from Adichanjangari Institute of Medical Science and MD Pathology from MPJ Medical College. She was working as an associate professor in Oxford Medical College and Research Center. Currently, she is the managing director of Mahesh Healthcare and she is the head and consultant pathologist at MHC Diagnostic. She also has numerous articles to her credentials, which is published in both national as well as international journals. Apart from that, I know her personally since 5 years. She is an extremely warm and kind person. She is very driven. She is motivated and immensely knowledgeable. I request Dr. Divya to please take over the session.
Thank you, Meenu. Thank you for the introduction. So, without delaying much, we'll just get into the topic. So, today's topic is what is our role in the diagnosis, monitoring, and the management of diabetes. So, before going into the topic, first we all of us need to understand what is diabetes. So, diabetes is a condition where there is a group of metabolic disorder which will cause increased blood sugar, that is hypoglycemia, which can occur because of the defect in insulin secretion or defect in insulin action, or it can be both. There is insulin secretion defect and insulin is not acting well. So this condition will cause diabetes, that is increased blood sugar. Why should it be treated? It should be treated because if the blood sugar levels are high for a longer duration, we call it as chronic hyperglycemia. It can affect the vital organs like eyes,
kidney. Dr. Divya, everyone, are you able to see the screen?
No, we cannot see.
You're not able to see?
You have to select the window. Okay. We can just see your mirror effect. We can't see your PPT.
Now? Can you see now?
No.
Now,
We can see your screen, Divya. Now you have to select the PPT. We are just seeing mirror effects.
Yeah, right now.
Yeah.
so what is diabetes? Okay, diabetes is a condition where there is increased blood sugar, that is hyperglycemia, which occurs because of defect in the insulin secretion or defect in the insulin action. So it should be corrected and it should be diagnosed at appropriate time. Otherwise, it can lead to chronic hyperglycemia, which can affect eyes, kidney, nerve, and other important organs. So, once there is blood sugar enters the body, there will be a hormone called as insulin, which will be produced from the beta cells of the pancreas. So, pancreas is an organ which is present, which will produce. There are different types of cells. Among that, beta cell will produce insulin. So, once the insulin is released, it will go and act on different organs and it will make up the glucose utilization. If insulin is not produced or if it is not acting on appropriate organs, the blood sugars will not be reduced. So this particular point is very important to understand which type of diabetes and to also to diagnose whether it is type 1 or type 2. So once there is high blood sugar in the body, insulin will be released from the beta cells of the pancreas. It will act on the different organs to reduce the glucose level. If the insulin is not produced from the beta cells of the pancreas, it can be because of the destruction of the beta cells of the pancreas, that is absolute insulin deficiency will occur, that will produce type 1 diabetes. Whereas in type 2 diabetes, beta cells are normal, insulin is produced normal, but it is not acting adequately on the other organs because there is resistance to the insulin on the receptors. That will produce type 2 insulin. So I want everybody to be clear between type 1 and type 2 diabetes mellitus. So type 1 diabetes mellitus is a condition where there is absolute deficiency of the insulin because there is defect in the production of the insulin. So this is type 1 diabetes, that it can be because of immune mediated or idiopathic. Next is type 2 diabetes, which occurs because of the insulin resistance. There are other types of diabetes also, like it can maturity onset of diabetes in young individuals, or genetic defect in insulin action, or some defect in the exocrine pancreas, some diseases of the exocrine pancreas, or endocrinopathies like acromegaly, Cushing syndrome. All these conditions also, or when there is some disease in the pancreas also, insulin cannot be produced. Even then, it can produce diabetes. But exact identification of which type of diabetes is very essential for the further treatment. And the last one is gestational diabetes. Gestational diabetes is a diabetes which occurs only in the pregnancy. After the delivery of the baby, the individual will be having normal sugar. So that is gestational diabetes, the diabetes which occurs in the pregnancy. So how do we identify the blood sugar? That is, we have different tests. In urine, we can identify by glucose, ketone bodies, and microalbuminuria. In blood chemistry, blood glucose estimation, glucose tolerance test, glycated hemoglobin, lipid profile, and serum insulin or C-peptide level. So, what are the symptoms of diabetes? Symptoms of diabetes are excessive thirst, excessive hunger, unexplained weight loss, blurring of the vision, slow healing of the wounds, feeling excessive tired, vaginal infection, frequent urination. These are the normal symptoms of diabetes. We need to know because there are so many times when we do a random blood sugar level, it can be high or it can be low, but we have to compare, we have to ask the history of the patient. So at least even the lab professionals also should know what are the symptoms of diabetes. So when we check the blood sugar in the fasting state, if it is less than 100, it's normal. If it is more than 126 in fasting state, it is diabetes. If it comes between 100 and 126, it is called as pre-diabetes. When we do oral glucose tolerance test or after food, after 2 hours after the food, if the sugar levels are less than 140, it is normal. If it is above 200, we term it as diabetes. Again, if it comes in between 140 and 200, we term them as pre-diabetes. What about HbA1c? HbA1c, if it is less than 5%, 5.7%, it is normal. If it is above 6.5%, we term them as diabetes. If it comes between 5.7 to 6.5, we term them as pre-diabetes. Okay, this is very important, this reference values. So the current criteria for diagnosis of diabetes is when HbA1c is above 6.5%. Fasting plasma glucose, if it is above 126, or 2-hour post-load plasma glucose concentration if it is above 200 milligram per deciliter. And classical symptoms of diabetes. If we find any of the two present, we can term them as diabetes. But remember, HbA1c, if you are using it to call, if it is above 6.5%, if you are using that alone, that HbA1c mission should be certified by the NGSP, and it should be, that is a National Glycemic Control Standardization Program. They will issue a certificate that this particular mission is standardized and it can be used for HbA1c, because now, so there are so many missions which we use for HbA1c, but when we are using that alone as a criteria, that particular mission should be standardized and it should be certified by NGSP. So coming to the other laboratory test for diagnosis, that is estimation of the blood glucose, that is fasting blood sugar, random blood sugar. So measurement of these blood sugars, which will just tell the current state of carbohydrate metabolism. So when we compare to the 100 ml of plasma, and when we compare it to the whole blood, in 100 ml of plasma, there's 15% of glucose is more, because in the whole blood, it will be concentrated by proteins. And when we come to the capillary blood, it will have 5% more than the random blood sugar. That is when we do the glucometer. So coming to the collection of specimen, when we are collecting the blood specimen, blood for the for testing the blood sugar, it should be an hemolytic sample. It can be in the serum sample or plasma sample. It can be in a heparin tube or EDTA tube, but it should be an hemolytic sample. When we collect it in the serum tube, heparin tube or EDTA tube or serum or plasma, the stability will be there for 8 hours when it is kept at 25 degrees Celsius. If you keep it at 4 degrees Celsius and refrigerate, you can use it for 70. You can recheck it within 72 hours. But if you are using sodium fluoride tube, we have an added advantage, that is it can be kept for 2 days at the room temperature and for 7 days when it is refrigerated between 4 to 8 degrees Celsius. So what are the methods used for estimating glucose? We have different methods, that is chemical method, enzymatic method. In chemical method, there is different Folin-View method, Somogyi-Nelson method, orthotolidine method. Coming to enzymatic method, which we all use, glucose oxidase, peroxidase method, hexokinase method, and glucose dehydrogenase method. So, Folin-View and Somogyi-Nelson method have the same principle, that is, we use a chemical, that chemicals, cupric ions will convert into cuprous ions to form a blue colored compound that will be measured by the wavelengths produced, and which will give the estimated glucose. Similarly, orthotolidine method, when we use the chemicals orthotolidine with glucose, it will produce a green color. The intensity of this will be measured at 620 to 660 nanometer. But all these methods, let it be Folin-View method or orthotolidine method, all these methods are now outdated and not used much. The most commonly used test in all our labs is glucose oxidase or GOD-POD method. What happens here is the glucose will combine with the oxygen to form gluconic acid and water. This will combine with the phenol in the presence of peroxidase enzyme that is chemically available in the reagent, and it will form a pink color complex. This will be measured in the wavelength of 530 nanometer. This intensity will be measured and the exact value of the glucose will be produced in the machines. Next is the hexokinase method. In hexokinase, first the glucose will combine with ATP and this will produce glucose 6-phosphate and ADP, and this will produce the final complex, that is NADPH. How much of NADPH is produced is directly proportional to the amount of the glucose, and that values will be displayed in the machine. So these enzymatic method compared to the chemical method, it's more accurate, it is more sensitive, it is very easy to handle, and very less sample is required. The very important more is the advantage of this enzymatic method is even up to 700 milligrams of glucose can also be identified in this method, and the sodium fluoride also will not appear in this assay. So accurate measurement of the glucose in the body fluid is very important, not only for the managing diabetes, but also we should know high levels of glucose is seen in other conditions, like in patients who are receiving IV glucose fluids during severe stress and in cerebrovascular accident. So just if you see there is high blood sugar and do not dispatch the report if it is a new patient, kindly correlate. Can you take the history? Is the patient diabetic or not? Or is the patient taking any IV glucose solution or not? Okay, because so many times it can be misleading. And whenever we get very low level of glucose, kindly again correlate with the history whether the patient is taking any insulin therapy or any other inborn errors of metabolism. Little bit like at least even any lab professionals can talk to the clinician and correlating with the history and then dispatch the report, it will reduce most of the errors from the lab. Next is very important, that is glucose tolerance test, which we call it as GTT. What is this? GTT is nothing but, or the glucose tolerance test is ability of the body to utilize glucose in the blood circulation. So what does the American Diabetes Association says? Do not use this GTT test for routine diagnosis or to confirm this particular patient is having diabetes or not. No, do not use that regularly. But what does the WHO say? You can use GTT to diagnose in the patients who are having impaired fasting glucose. So what is impaired fasting glucose? When the normally when you do FBS, if it is less than 100, it is normal. When you get 100 to 126, we call it as pre-diabetes, right? So that is called as impaired fasting glucose. So even those patients who are having impaired fasting glucose, those patients can do GTT and confirm whether they are having diabetes or not. But American Diabetes Association and WHO both recommends kindly use this GTT for diagnosing gestational diabetes. Okay, it is usually done in 24 to 28 weeks. During that duration, we can use for diagnosing GDM, but do not regularly use for diagnosing diabetes patients. So when do we use this GTT? In asymptomatic patients, that is patients who are not having symptoms of diabetes, but they have glucose in the urine. For them, you can confirm with GTT. Second, in patients they have symptoms of diabetes, but there is no glucose in the blood level or in the urine level. For them, it will be normal. Urine and blood, when the glucose level is normal, but they have symptoms of glucose, yes, you can do GTT. Third one, if the patient has a family history of diabetes, but no symptoms or positive blood finding, you can do GTT. All this, it will say in the pre-diabetes condition only, you can diagnose whether this patient will get diabetes or not, or how well the patient is tolerating the glucose when we are given the required or exact amount of glucose solution. So when we should not do GTT also, we should know. Do not do GTT in a confirmed diabetic patient, because already in diabetic patient the glucose level will be very high. By giving glucose solution like say 75 gram or 100 gram, actually will be causing more harm to the patient than you will be helping the patient. So do not do it in a confirmed diabetic patient. Do not do it for any follow-up, like in any patient who was taking treatment. If you are doing it for follow-up to see whether the blood sugars are normal or not, it is not recommended and it is not advised also. So, and do not do it in any ill patients. So we all talk about GTT. So we should be aware there are different types of GTT, and also we should know what are the differences of this GTT. So OGTT, that is oral glucose tolerance test. IV GTT, that is for the individuals who cannot take orally glucose, we can give it in the IV formats. Next, third one is mini GTT. So we'll discuss each one in detail. Whenever you are doing GTT, glucose tolerance test, remember preparation of the patient is must. Why I am saying preparation of the patient is must? Because there's something called as glucose challenge test, that is GCT. For that, preparation of the patient is not required. When we are doing GTT, preparation of the patient is required. Patient should, how will you prepare? Patient should be on a carbohydrate and restricted diet. That is, he should be normally taking his food. And he should be ambulatory. That is, he should be moving around. That is, he should not be on bed rest. Third one is, after giving the first sample, ask the patient, do not smoke or do not do heavy exercise or do not drink coffee or tea until he gives the second hour and third hour sample. So this preparation is very essential when you are doing GTT. I want everybody to remember what is the difference between GTT and GCT. In GTT, you will prepare the patient. In GCT, that preparation is not required. So when we are doing OGTT, that is, you will ask to prepare the patient, that is 8 to 14 hours, he will be in the fasting state. You will give the first, you will collect the first sample, then you give 75 grams of anhydrous glucose. Okay, please remember 75 grams of anhydrous glucose is dissolved in 250 ml of water. You should have a weighing machine. You should exactly weigh 250 ml of water and 75 grams of glucose solution, and then it should be given to the patient. He should drink within 5 minutes. If you are doing it for children, you might ask, why should I do it for children? Yes, because most of our type 1 diabetes occurs in young children also. So when you are when OGTT is asked for those particular patients in the young individuals, you can give 1.75 gram of glucose per kg. So if the kids is 20 kg into 1.75 gram, and whatever the dosage you get, that we will mix it with 250 ml of water and we will perform the OGTT test. Best is readily available glucose drink solutions are available. That is 75 gram, 100 gram is there. You can use that, or you can, sachets are also available. That is 75 gram and 100 gram glucose sachet. You can use those solution also. And you might get about, some people use 75 gram of glucose, some people use 100 gram of glucose. So when you are using 75 gram of glucose, you have to collect 2 samples at next 2 hours. That is, after giving 75 gram of glucose, you will take the first sample at 1 hour and the second sample on the second hour. If you are giving 100 gram of glucose solution, you should take 3 samples at first hour, second hour and in the third hour. Okay. So OGTT is recommended for all gestation to diagnose gestational diabetes mellitus patient, to diagnose impaired glucose tolerance patient, and also in evaluating in the patients who are having neuropathy, nephropathy, those particular patients also. So normally when you collect blood sample, collect a urine sample also and check for the urine sugars also. And a curve is obtained. So in the normal individuals, what will happen when you give a glucose solution, that is 75 gram or 100 gram of glucose solution is given, it will raise up to 100 to 120 and slowly it will increase up to 140, but it will reduce within 2 to 3 hours. But what happens in the diabetic patient, immediately after giving glucose solution, within half an hour, the values will increase up to 250 milligram per deciliter and it can go up to 300, but it will never come below 200. After giving the glucose solution, even when you check at second hour and third hour sample, the values will not come less than 200. So those particular individuals we will term them as diabetes patient. If the values is between 150 to 200, we will term them as impaired glucose tolerance. So after giving glucose solution, if the values are not coming less than 100 after on the second hour or on the third hour, we term them as impaired glucose tolerance or pre-diabetic patients. They have chances of again getting diabetes. So what if the patient cannot take orally glucose, or if they have some intestinal problem, or they are allergic to glucose solution, and you have to diagnose. That time you can give intravenous GTP. So in these conditions, we'll give 25 gram of glucose dissolved in 100 ml of distilled water over 5 minutes. After the infusion, you will take the blood sugar. You will check the blood sugar every 10 minutes once up to 1 hour. So what will happen initially? There will be within 10 minutes the blood sugar will shoot up, and in the normal individuals in 1 hour it will come back to normal. But whereas in diabetics it will not be less than 200. But in normal individuals it will immediately drop. After 1 hour it will drop and it will come back to normal. So this is the test followed for individuals who cannot take orally glucose. So what is this mini JTP? See, most of the time when we give, we cannot collect key samples, that is 1 hour, 2 hours and 3 hours. So WHO has recommended just 2 sample techniques. Just take the 0 hour, first you collect the sample, give 75 gram of glucose. After 2 hours, take the second sample and give the values. The same time, collect the urine and then correlate. Because most of the patients may not be willing to give the blood sample at every 1 hour or 2 or 3 samples. Nobody will be willing to give. So this is the modern GTT which is followed regularly everywhere. So normally in normal individuals at fasting state, normal persons will have less than 110, and after 2 hours it will be less than 140. If it is above 200 after 2 hours, and if it is above 126 at fasting state, we call them as diabetes. If it comes in between 100 to 126 in the fasting, and after 2 hours it is between 140 to 200, we term them as impaired glucose tolerance. That is, they are not able to tolerate the glucose solution what we are giving. Then we will term them as impaired glucose tolerance. So there are certain factors which will affect this, and it can give again abnormal values also. In individuals who are having acute infection, because for them there will be cortisols which will be secreted and the curve can be prolonged. That is, the blood sugar can be prolonged high. In hypothyroidism patient, blood sugar may not show a correct value at all. And in the individuals who are on starvation for a longer duration, like especially when they are during fasting for 1 month, so even that time doing GTT is not advisable because we will get wrong values. Okay. Now we will come to GCT, that is glucose challenge test. So what is this glucose challenge test? Here we give 50 gram of glucose orally and then test within 1 hour. Remember, here fasting is not required. Preparation of the patient is not required. Just give 50 gram of glucose and test within 1 hour. If it is less than 140 milligram per deciliter, it is normal. If it is above 140 milligram per deciliter, again you have to, GTT is indicated. Do the oral glucose tolerance test. So if it is above 200 or above 140, we will term them as gestational diabetes. I told you, gestational diabetes is a condition where diabetes occurs only during pregnancy. Why it occurs during pregnancy? Because insulin resistance occurs in pregnancy because of the hormonal variation. So only during that time they will have diabetes. Exact identification and exact test should be done to identify whether the patient is gestational diabetes, because if it is not treated, the kid can be affected, the neonate can be affected. So who are at risk? Who should be screened for gestational diabetes? The ladies who are at less than 25 years of age with normal body weight and no history of diabetes are very at low risk of getting gestational diabetes. The high-risk individuals are markedly obese ladies with a strong family history of diabetes mellitus, glucose in the urine, and the previous history of gestational diabetes should be screened OGTT at 24 to 28 weeks. Normally, in the pregnant ladies, when they come, you can just do the fasting blood sugar or the random blood sugar. If it is above 200, we can term them as gestational diabetes by repeating the test again 2 times on the subsequent days. If it is above 200. But if it comes below that or if it comes normal also, OGTT is indicated. Or you can do GCT, and again if it is impaired, then you can do OGTT. So after reading OGTT, we can know we can come to the conclusion there is 2 approach. One is 1-step approach and then 2-step approach. In 1-step approach, simple, give 100 gram of glucose and do after 3 hours OGTT is performed and correlate with the values. In the 2-step approach, that is GCT, first give 50 gram of glucose irrespective of the meal, even when the patient is not prepared. Check the blood sugar. If it is above 140, do the exact OGTT. Otherwise, if it is less than normal, the patients are at less risk of developing GDM. So the values you can correlate at first hour in the fasting state, it should be less than 95 milligram per deciliter. In the first hour, it should be less than 180 milligram per deciliter. In the second hour, it should be less than 155. And in the third hour, it should be less than 140 milligram per deciliter. Anything above this, anything values deranged, we term them as gestational diabetes. So coming to the laboratory test for screening of diabetes. So ADA and WHO recommends the screening test for diabetes is FBS, that is fasting blood sugar, and OGTT. So these are the 2 normal things which if we want to do in screening for diabetes, fasting blood sugar and OGTT. Who are the high-risk individuals who should be screened? Highly obese individuals and individuals with family history of diabetes mellitus, dyslipidemia, and impaired glucose tolerance. See what happens in this obese individuals or family history of diabetes, the receptors where the insulin should go at, they will become resistance will occur. So because of that, they will get diabetes. So these individuals should be screened for diabetes. So screening test is performed at earlier age, 30 years, and it is repeated once in again 2 to 3 years. So next, coming to laboratory test to assess the glycemic control. So how well or how is the blood sugar when in the patient who is taking treatment? So we have 2 methods, that is HbA1c method and self-monitoring of the blood glucose, that is using glucometer. So we always do this test HbA1c. What is this HbA1c? What happens is when the glucose enters the body, some amount of glucose will combine with the hemoglobin and it is called as glycoglobin. Once this is formed, glycated hemoglobin is formed, it will stay in the RBCs for 120 days. That is the lifespan of RBC is 120 days. As long as the RBC is there, that glycated hemoglobin will be there. So we can assess the average blood sugar retrospectively. That is, we can go backwards and we can detect. See what happens in the fasting blood sugar and in the postprandial blood sugar. If it depends on the current state, that is, in the previous night, if he was on the fasting, or if he has not taken the diet, or due to many other reasons, we can get errors in those blood sugars. But this HbA1c, it will tell what was the average blood sugar in the past 2 or 3 months. So that is when we use glycated hemoglobin. So HbA1c gives information about the average blood glucose concentration over the retrospective. That is, we can go backwards and we can say what was the average blood sugar over past 2 or 3 months. normally, so the blood, our hemoglobin percentage is 12 to 14%. So in that 5% of hemoglobin will be glycated. Normally, the 5% of hemoglobin will be glycated or less than that. If it is above that, that is, if it is above 6.5% of glucose, if it is hemoglobin is glycated, then we term them as diabetes. So this HbA1c is more informative, like any diet, exercise, or the insulin will not affect the test results. And HbA1c of 6% will correspond to 135 milligrams of blood sugar. So anybody who is having more than 6.5%, we will term them as diabetes. In the individuals who are on treatment, like insulin or oral hypoglycemic drug, we will do regularly this HbA1c in the diabetic clinic, and they will assess whether the treatment is good or not, or it should be changed, or it should be changed to any other better medication. Because in the individuals who are having HbA1c of less than 7%, it tells that the diabetic about 10%, it is fair control. If it is about 13%, the individual is having very, very poor control over his blood sugar. He is in the risk of getting macrovascular complication. If it is in 10%, he is in getting microvascular. That is, microvascular means they are about to get damage the kidney or eyes. If it is macrovascular complication, if the HbA1c is very high, it means that there are chances of blood clotting, like it can affect the heart or it can affect the major organs. So HbA1c is very important. Second thing is, there are different methods of HbA1c, like HbA1c electrophoresis, HPLC method, immunoassays method, colorimetric method. But actually, most of the methods will not be standardized. It should be standardized and it should be certified. Whatever HbA1c machine you are using, it should be standardized by glycohemoglobin control, and it should be certified. You should have a certificate that it is standardized. Only those HbA1c values are appropriate, especially when you are telling this particular patient is having diabetes. So at what interval HbA1c should be determined? In type 1 diabetes, who are on minimal therapy, like mild doses of insulin, you should do at least 4 times in a year. That is, once in 3 months, it is recommended. If in type 1 diabetes mellitus, who are on high dose of insulin levels, you should do it at least every 2 months. In type 2 diabetes mellitus individuals, especially who are on simple oral hypoglycemic drugs, you can do once in 2 years, that is once in 6 months is recommended. Remember, HbA1c can be high not only in diabetes mellitus, it can also show high values in PCODs, in other conditions of hypoglycemia, in glycosuria conditions also. Low values can be seen in hemolyzed specimen, hereditary HPF, that is in thalassemia fetal hemoglobin, when it is high, it can give a wrong result. In neonates, pregnancies, fetal maternal transfusion can also give wrong values. Hemolytic anemias, chronic blood loss, chronic renal failure. So in these individuals, HbA1c can give wrong values. So we should know these conditions. Whenever HbA1c is abnormally high or abnormally low, we have to rule out this causes. So little bit history by the patient will help us to give the correct report. If the values and if the history is not matching, we can repeat the test by the different method. HPLC method is the most standard method for doing HbA1c. So HbA1c, I told you, less than 7% is good glycemic control. HbA1c above 8%, treatment should be given. So next method for assessing glycemic level is self-monitoring of the blood glucose. That is using the glucometer, using strips and glucometer. This can be done at home by the patient itself. So this is more simpler form of assessing glycemic control. But the only problem with this self-monitoring, that is using glucometer, is when the blood sugar is very high or very low, it can those reports are results are not reliable. And also, the patients who are using this glucometer devices at home, it should be checked by with random blood sugar in the good lab also. So next is assay. So I told you HbA1c in certain conditions like hemolytic anemias. So there are, in those conditions, HbA1c may not be correct. So when we have doubt and those conditions and we want retrospective over the 2 weeks, or when we have started a new medication and when we want to know just within 2 weeks whether that medication is correct or not, that time clinicians advise fructosamine assay. Fructosamine assay, similar like HbA1c, we can see the glycated proteins. So again, there are reagents available for this fructosamine assay also. And also in the pregnancy, HbA1c may not be more reliable because the patient will come around 5th month or 4th month. We cannot see whether that particular pregnant lady was having sugar 3 months before or 1 month before. In those pregnant ladies also, to rule out GDM also, we can use fructosamine assay to see retrospectively whether that particular patient had diabetes or not. Next is glycosylated albumin. Similar like HbA1c and fructosamine assay, this glycosylated albumin reagents are also available. This one also can retrospectively, that is 15 days back, what was the sugar level. So that can be identified by glycosylated albumin. Next is insulin assay. So in certain, like in type 1 diabetes mellitus or in type 2 diabetes, in the initial diagnosis, we need to assess whether the insulin is released or not, or in the patients who are taking insulin treatment, whether the insulin is there or not. To identify that, insulin assay can be done by using radio immunoassay technique and ELISA technique. Next is pro-insulin assay. What is this pro-insulin? When the beta cells releases insulin, it will be released in the form of pro-insulin. Okay, this pro-insulin cannot go and act on the any organs. This will be converted into insulin, and then only those insulin will be active. Why testing insulin from the body is very difficult because its half-life is only 5 to 10 minutes. So it will give most of the time checking insulin will get a wrong report. So best is to check pro-insulin assay. So this pro-insulin is more active form and it will give the exact value whether this particular patient is producing insulin or not. Whether this is type 1 diabetes mellitus or type 2 diabetes mellitus. Remember, type 1 diabetes mellitus can occur in old age also. Type 2 diabetes mellitus can occur in young age also. So how will we differentiate whether it is type 1 diabetes or type 2 diabetes is depending upon the pro-insulin levels and the C-peptide levels. So what is C-peptide? Once the pro-insulin is released from the beta cells, the pro-insulin, before converting into insulin, it will release the C-peptide. C-peptide is most commonly done test to diagnose whether it is type 1 diabetes or type 2 diabetes. Once the pro-insulin is released to insulin, C-peptide levels will be there in the serum for a longer duration. So exact measurement of C-peptide will proportional to the exact amount of the insulin level. So if there is good amount of C-peptide in the serum, it tells that there is good amount of insulin. If there is good amount of insulin, it says that beta cells are functioning properly. It is not type 1 diabetes. And also, in case of insulin poisoning, for example, if the patient has taken excessive insulin dosage, or in suicidal tendency, if the patient has taken excessive insulin level, if we have to identify, we have to check the C-peptide level. If they are taken from outside insulin, C-peptide level will be low or it will be normal. Okay, so if the C-peptide level is normal and if the insulin levels are high, it indicates that the patient has overdose of insulin. Next is coming to the urine glucose excretion. Normally, in the urine, the glucose produced or released is 15 milligram per deciliter. Anything above that will cause urine glycosuria. So we have different types of glycosuria. When there is pathology in the kidney, we call it as renal glycosuria, and when there is the problem in the alimentary tract, that is when GIT or when there is a problem in intestine because of some storage disorder, and when it cannot absorb the glucose properly, it will be secreted in the urine. That is called as alimentary glycosuria. So we have different types of tests available for checking sugar in the urine. That is most commonly used test is BENEDICTS test. We all know in BENEDICTS test we take 5 ml of urine and add 5 ml of reagent, add 8 drops of urine and keep and see for the color change. Depending upon the color change, we will grade that 1+, 2+, or 0.5 gram or 1 gram of sugar is present in the urine. Second is tablet forms are also available, and the color change of the tablets is also correlated to the amount of sugar present in the urine. And we commonly use this reagent strip. So even that strips also works on the principle glucose oxidase and peroxidase method. So depending upon the color change, grading is given, and depending upon the grading, we can estimate how much of sugar is present in the urine. And one thing what we all have to remember is false positive reports can also come whenever some oxidizing agent in the urine container. So if the symptoms are not matching, kindly repeat with a fresh urine sample. So what are tests available for the assessing the risk factors? So what are the risk factors? I told you there are microvascular complications and macrovascular complications. So microvascular complications are identified by the amount of the protein excreted in the urine. So normally some amount of albumin can be excreted that is less than 20 milligrams. If it is more than that, we call it as proteinuria. If it is more than 300 milligrams, we call it as proteinuria. This microalbuminuria test should be done regularly on diabetic patients. When should we do? If it is a type 1 diabetes mellitus, we should do 5 years after the diagnosis. If it is type 2 diabetes mellitus, immediately during the time of diagnosis, please check for microalbuminuria, because we may not be aware when the diabetes has started in the type 2 diabetes mellitus patients. So for checking this proteinuria, there are different types of tests available. So in urine, for checking protein, we have 2 different tests, heat test and sulfosalicylic acid test. So heat test, take 2/3 ml of urine and heat just the upper part. If the turbidity occurs, just add some 2 drops of glacial acetic acid. If phosphates are present, it will clear and it will tell whether the protein is present in the urine or not. Next is sulfosalicylic acid test. By sulfosalic acid test, you take 5 ml of urine in the in a tube and centrifuge it and add 2 to 3 drops of sulfosalicylic acid. If a coagulum is formed, we'll see the coagulum and will grade as depending upon the turbidity whether and also whether the granulation is present forms. We give it as 1+, 2+, 3+, and 4+. And also reagent strips are available to tell the grading of the proteins in the urine. Next is I told you about microalbuminuria. Normally, the albumin present in the urine is less than 30. If it is between 30 to 300, we call it as microalbuminuria. See, what we spoke about previous heat coagulation test is when there is overt proteinuria, but that is whenever the protein is more than 300 milligrams. But if we detect in the microalbuminuria level only, most of the complications can be prevented. So we can do 24-hour urine collection, short-time urine collection, spot urine albumin sample, urine albumin creatinine ratio also can be done to detect the microalbuminuria levels. So microalbuminuria present, it indicates that there is some capillary damage to the, it not only tells the kidney is getting damaged, it also tells the retina, the retinal blood vessels are also getting affected. So doing this microalbuminuria test is very important. So there are different strips available. One is albumin to creatinine ratio strips are available. So we can, depending upon the color change, we can give the values. If it is positive, we have to do quantifying test of microalbuminuria, and the exact amount of microalbumin present should be done by repeated testing. So another one, microalbuminuria strips are also present. That is, two colors will be there. If red color is present, it indicates that this is usually done for the screening when there is more number of patients, just to screen whether the microalbumin is present or not. So to identify exact quantity of microalbumin, there are different tests available. That is colorimetric test, ELISA test, radioimmunoassay, immunoturbidometric method, nephrometry, and chemiluminescence methods. The last is all diabetics should be ruled out for lipid profile. Fasting lipid profile is very important. So depending upon the levels, if it is less than 150, those people, if the triglycerides level is less than 150, they come in the low risk. If it is 150 to 300, it comes in the intermediate risk. More than 200, it comes in the high risk category. Similarly, LDL cholesterol and HDL cholesterol also should be done, and it should be, patients should be categorized whether these particular patients are under risk of developing macrovascular complications. That is, because of the high level, it can affect the heart and other major organs. So we have to know a little bit two slides about acute complications of diabetes mellitus. So already what all this while we read was chronic complications. The blood sugar level is there for a longer duration. But certain times high blood sugar can cause immediate problems also. That is diabetic ketoacidosis and hyperglycemic hyperosmolar state. And third one is hypoglycemia. What is this diabetic ketoacidosis? This occurs in type 1 diabetes. What happens in type 1 diabetes is complete absence of insulin can cause high blood sugar. At the same time, they will have acidosis, that is increased ketone body production in the blood, and it can be excreted in the urine. What is our role in that? We have to identify in the urine whether there is increased production of the ketones or what. So little bit history again is important. Well, what is the symptoms of the patient? Is the patient vomiting? Is the patient having stomach pain? And how? So little bit, not completely you have to know, but we should be in the position that when we see ketone bodies in the urine, when we see sugar in the urine, kindly correlate or immediately inform the clinician the ketone bodies is present in the urine and there is high blood sugar. So this will give the hint to the clinician that this particular patient is diabetic ketoacidosis. We have to do ABG also for those particular patients, because ABG also confirms this diabetic ketoacidosis. That is, I'm sure most of them would have been seen this ABG values also. They will have high anion gap, low bicarbonate level, and PCO2 level. So correlating with this history, with these values, we will be helping the patient and also the clinician in diagnosing diabetic ketoacidosis. So how do we check for ketone bodies in the urine? We all know strip method, it will be identified, but we have to confirm by the biochemical test. The most commonly test used is ROTHERA'S test. To take 5 ml of the urine sample, saturate with ammonium sulfate and add crystals of the skim mixoprotide, mix it well and add the liquor ammonia along the side of the test tube. If a purple ring is formed, it means that ketone body is present. Next is GERHARDTS test, that is adding 10% of ferric chloride solution to the urine sample will give a reddish purplish color. This will tell acetic acid is present, that is nothing but a ketone bodies. Second state is hypoglycemic hyperosmolar state. This is a condition which occurs, complication which occurs in type 2 diabetes mellitus. What happens here is there will be high blood sugar. Ketone bodies may not be present, but they will be having high blood sugar and acidotic breathing. So this is another complication of diabetes. The third complication of diabetes is hypoglycemia. So in a diabetic patient, when you see very, very low blood sugar, that is when the plasma value is less than 55, again it is a critical value. You should inform immediately to the staff nurse or immediately to the doctor. And also kindly point whether this is a diabetic patient, whether this patient is on insulin level, because if the patient, when you see the plasma glucose level less than 55 and if the insulin is growing, immediately you have to inform so that doctors can change the treatment. So summarizing the whole presentation, we all have to know what is the definition of diabetes. And what are the types of diabetes we saw? That is type 1, type 2, GDM. What is the main difference? What is the test which is done to identify whether it is type 1 diabetes or type 2 diabetes? Next, what are the tests used for diagnosing diabetes in the blood sample, the urine sample? If the complications have occurred like diabetic ketoacidosis, what else we have to see in the urine? And next, for monitoring of the diabetes, what are the tests used? Like HbA1c method and self-monitoring blood glucose, that is glucometer method. And what are the tests which are available for to prevent complication, and if the complication has occurred, what are the tests used? So I conclude by saying diabetes is a very complicated disease. Anyone at any age can have, despite of the negative family history. So just don't assume type 1 diabetes occurs only in young, type 2 diabetes occurs only in old. It has to be diagnosed because there are different antibody detection also to identify what type of diabetes, type 1 diabetes it is. So our lab plays a very important role in diagnosing the diabetes and also in the care of healthy patients. Thank you.
Thank you, Dr. Divya. That was an extremely interesting and educative section. And it has definitely left us with an enhanced understanding about the diabetic. Now we will come to a question and answer section. I request our audience to clear their queries, if any, with our speaker. Any questions? Dr. Divya?
Yeah.
One query from my side. Nowadays, we have seen many cases like with the PPBS lower than FPS.
Yeah.
Is there any specific mechanism for this? Yeah.
Yeah, when FBS is having a high value, when you compare it to the PPBS, see, we have to see whether it is in a diabetic patient. Yeah, most of the time when we are seeing FBS and PPBS, it will be an established diabetic patient who is on treatment. So when the fasting blood sugar is low, most of the patients will be on therapy. Like insulin therapy, there is different types of insulin, long-acting insulin, intermediate-acting and short-acting insulin. Most of these patients would have been taken long-acting insulin with the higher dose levels. So that needs to be changed. Second thing, there's something called as Somoki phenomenon. Normally what happens between 3 a.m. to 8 a.m. in the morning, there will be decreased insulin production. So there should be high blood sugar. So when this is occurring, it means that there is the Somoki phenomenon has occurred because of rebound phenomena. There is high blood sugar. So for these particular patients, when there is FPS values are deranged, we ask them to check 3 a.m. blood sugar with the help of a glucometer. So that will give the exact value, whether it is because of the insulin production from the body or it is because of the insulin treatment which patient is taking.
Okay, thank you, Divya. There is one more question. Can we do urine albumin and creatinine on routine biochemistry analysis?
Urine
albumin and creatinine on routine biochemistry analysis?
Yes, it can be done in the normal biochemistry analysis, like how we do for fluids, like we do for ascitic fluid, pleural fluid. Similarly, fluids can also be tested in the normal biochemistry machines.
Okay. Any other question? Any dilution is required for the same?
Yes, 1:10 dilution is required.
Okay. there any specific test to distinguish between type 1 and type 2 diabetes mellitus?
Yeah, because see, type 1 diabetes, I told you, it is mainly because of the defect in the insulin production. So C-peptide level. So in type 1 diabetes, C-peptide levels will be very low. If it is a type 2 diabetes,